And let's just hope the laptop doesn't die or whatever this is. An iPad. How high do I need this?
I have my hair up so I don't touch my microphone the whole time.
This is going to have to go down here. Okay. We can just start.
Hi.
Hi.
We're having a Monday over here.
This is a very Monday of Mondays. It's raining. It's Monday.
Yeah.
We don't have our mugs.
But we are caffeinating.
But we are, I had 6 cups of coffee this morning. Well, I think, when you when you make the...
In your little butt mug? Like that small? Or
when it's, you make a pot and the lowest it'll make is 6.
Oh, yeah, so you just drank it. So you had a pot.
I was going for it. I went to the gym this morning.
Good for you. I did too.
Wow.
Lifting weights.
So healthy.
Trying to practice what we preach.
Yeah, wait till you hear what we talk about today.
Mm-hmm.
This is going to be episode 4 of Coffee Talk. We want to talk about estrogen going down, how it can affect the most common physical symptom, I guess, of menopause.
I think so. Well, one that
you know what I mean,
most
like
people have heard of.
Yeah.
Yes.
That it seems like there's no explanation for it and it doesn't make sense. So we want to hope to make some sense of it for you today. And that's going to be frozen shoulder.
Yes. Or clinically, they call it adhesive capsulitis.
Yes.
And when you just said, I cut you off right away, but you triggered me to recall that we learned in PT school, they call it insidious onset, meaning no idea why it's happening.
Oh, yes. Yeah.
But now
we know.
Yeah,
now we know. But there's different ways that we can have you look at it, because just because you have this pain, there are ways to combat this at early stages so we don't get to the later stages. So we want to basically just talk this out, even talk about some cases that we have, and really just explain this out for you. Okay. So like she said, insidious, right? It's just it's onset and there's no explanation to it. And so I think, I should have got the guy's name. I can't, he's like JL Hulks on Instagram. Love him. Okay. Orthopedic surgeon. So I got a lot of this material from him as well. Because he just explained it really, really good. So you might have not had a shoulder injury per se, but it's something that just starts hurting. And so it's when it comes to like the shoulder, when he sees women come into his office, he's a very, very busy orthopedic surgeon. When they're middle-aged, going through perimenopause and menopause, he says like there's just really no injury that happens. It's truly just an onset.
That's why they keep saying insidious onset. Yeah. People would come into the PT clinic all the time with this diagnosis.
It's true, and it's just like your estrogen is tanking. Now, let me ask you this though. Do you think because it's the biomechanics of what you've done with your shoulder over time that maybe it didn't present before, but because the low estrogen, it just makes you more vulnerable?
Yeah, that's a good question. I would think so, because I think with any human body movement pattern we see, often we can, when you have the time to really take a look at a patient and hear about their history, what sports they grew up playing, any injuries as a kid that would predispose them to maybe, if we're talking about shoulder, abnormal movement there.
Yeah.
I wonder too, now that we're talking, so I'm seeing more and more the generation, I'm 40s, you're 30s. I have a niece who's 20s.
Yeah.
And weight training is really a more popular movement for that younger crowd than when I was the cardio queen type
so you
generation.
Wonder if like that generation,
I wonder if we'll notice
these like people in their 30s and their 20s, are they going to have the same frozen shoulder symptoms? Because what is it, like 50% of women?
Yes, it's a super high percentage of women that have frozen shoulder. Again, unknown cause, between 40s and 60s. What's happening hormonally at that stage? It's kind of crazy that I never even thought about this and questioned what I learned in PT school.
We didn't have the education. Though.
No, but
we're not taught to really question that.
If it's females between like a different age group, like in your 20s, you're not going to think perimenopause, but this is peak perimenopause at 40.
Yeah.
Most are starting. I shouldn't say peak.
At least.
But between 40 and 60. So now I lost my train of the weight training. So as a PT and for you as a chiro and movement specialist, when we're looking at a shoulder, aside from frozen shoulders, any abnormality, don't you jump to scapula or the shoulder blade and look at in trunk? Like we start to look at not just where the pain is, we're going to where we're
going everywhere else, right? That helps the mechanics of
the shoulder. Because if you just treat here and you're not looking at all the buddies of the shoulder, like shoulder blade, your diaphragm, ribs, your glutes, and how you move, depending on, and I mean, if you were a thrower, you're going to really have to look at the foot and the knee and the hip.
Absolutely.
All to say that strength training is so important.
That we wonder if we're not going to see the same things
and it's just
coming
clicked as we're talking.
Yeah.
I would hope. That'd be awesome.
But there's such little research on this that we're not going to know for a long time.
Yeah.
So we're just going to use the information that we're now gathering and try and help women as much as we can during this time and understand that you don't have to go through this pain. There's ways to combat this, and we're going to get into it. So I think real quick though, like understand the corresponding loss of estrogen. It plays a role in your brain function, your bone, like thinking like osteoporosis, and then obviously the joint and tendons.
And inflammation.
So this is causing the inflammation. And so what happens is it's affecting the integrity and elasticity of the joint.
Yes.
And we'll talk about this study in a second with Duke, but you're going to get stiffer, then throw inflammation at it as well. So it's like your shoulder's getting stiffer because of like lack of estrogen.
Right.
Then add additional inflammation through perimenopause and menopause.
Right.
It's just like a perfect storm that happens in these joints. And
it's just brewing.
Not to just say this is only for frozen shoulder.
It could be in your hip and your knee and elbow.
Knee,
joint, all joint. Back, your spine, those are all joints.
Yeah. So it's, it's just very common. We see the shoulder, and like we said, like there's going to be more research with that.
Yep.
But understand, like if you've had a previous injury or previous something happen in any other major joints, you are more susceptible to this feeling elsewhere. So keep that in mind. But for this purpose,
falls, anything that prevents you from using that body part in its designed way.
Yeah, absolutely.
Losing mobility somewhere, even for a shorter period of time.
Absolutely. So, I mean, for this episode, we'll mostly just refer to frozen shoulder, but please keep that in mind.
Yes.
So I guess I'm gonna say this line, so because I think I understand it, because I put that in there.
Oh yeah. Yes.
So cytokines, they're your inflammation markers, correct, in the body. So they're gonna increase in menopause. Then these tend to go to the shoulder, which is gonna start to increase your pain. Okay, doesn't mean just yet where it's affected the joint itself, but eventually thickening of the ligaments and capsule of the shoulder, which then contributes to this overall stiffness. So see, this is like a domino effect that happens, and you're more susceptible to as a woman during menopause. You want to talk about a little bit if you have type 2 diabetes too?
Oh yeah. So
do you understand what I put for notes?
I know. Well, one, I'll read what Angela wrote. So graciously did some note keeping for us.
It's so sloppy though.
But yes, then I kind of recall all of this from school, which was a long time ago. But an increase in insulin resistance, which is one of the earliest markers of type 2 diabetes. And if you have this for 10 to 15 years, right, before in your blood glucose, then frozen shoulder is going to be much more common. So if you're female and you have the estrogen tanking working against you, and then you're also up against this insulin change of type 2 diabetes.
Or even if you're not fully type 2, but like on the cusp of like that pre-diabetes, like
then you're much more likely. Yeah. So it's important to keep that in mind.
So, more reason to make sure you're really healthy, eating whole foods, and consulting with your doctor about your blood glucose, and make sure your A1C is at the right levels. Make sure you monitor that if you are on the cusp, because you want to change that lifestyle and go back down so you're less susceptible to things like this. Right? So just keeping that in mind. But here's where we go to the first stage of what could happen in the shoulder, right? That's inflammatory. And like we mentioned before, that domino effect of what happens, you're going to have this overall pain. So this is usually about where people kind of go into the orthopedic, right?
Or ignore it for a while.
Or ignore it. So this is usually in all directions. Your arm hurts. So this is where I see problems. The good news in this phase that your capsule and is not thickened yet.
And the capsule is, we're talking about, so it's a ball and socket joint. So you have the ball, which is the top of your humerus, this arm, long muscle here, or long bone here, ends with a ball on it. And then from your shoulder blade, and then also your collarbone, we have our joint capsule, we call it. I know, I just have the pelvis. I don't have a full skeleton.
It's like
But it's like this. So the capsule, there's soft tissue in here. And your bicep tendon actually attaches up there in the labrum, right? This is like dusting off some anatomy here. And then we have some circulation. What else am I missing? And all the rotator cuff muscles are around here.
Bicep that's like another way to support.
But in terms of the capsule, that's what we're talking about. What's happening to the integrity in the joint itself.
Yes, it's really deep. Like we're really going truly to the joint, underneath the muscles there. So this is where I see a lot of people. You feel your shoulder hurt when you put it up here. You get scared. You keep it down. This is my biggest advice. Suck it up, buttercup. No, you want to make sure you don't avoid this.
Through some discomfort.
You have to move through the discomfort. But obviously, our initial brain response, like
I'll make it worse. I don't want to create a torn muscle or more inflammation.
You're absolutely scared. I don't blame you. But the more the more you don't put your arm through that full range of motion that you should have, you're more susceptible. This frozen shoulder is going to get worse and worse
because more inflammation will build, less mobility happening here. We already have the cacophony that we talked about of the estrogen, the cytokines, is that how you pronounce it, working against you. And then adding less mobility, which is another layer of creating the inflammation there.
Absolutely. So you have to not avoid this movement. You have to go through uncomfortable, and you'll know that you're going to get to a point where you have to see someone, because sometimes it's just going through this. Like sometimes you can avoid this whole issue as if you just like kind of go through, they call it like the painful arc. Like once you get past that hard, really point of pain, which is usually
it can
around
be right
here.
there. And there's a whole other, we talk about scapular plane versus frontal. And that's why I was going to say, we don't mean just continue doing what you're doing on your own. Because if you have impaired mobility, and I think most people walking around don't optimize. We have a low battery. I guess we have to be more efficient with our chatting. But I think this is really important in the basis of what we like to treat. A lot of people are walking around with rounded shoulders. They aren't weight training. They're mid-back enough, myself included. Past sports injuries, or it's overuse from what you do for your job, repetitive. If we don't want you to just keep working through pain in a dysfunctional pattern.
Exactly.
We want you to see a specialist who can help you optimize your body to move well, to reduce inflammation. Does that make sense?
No, absolutely. And those are like your signs of like, hey, you're more susceptible to this, is because there is a dysfunctional pattern. And let's say you're at home and you're trying to do this and you get past the point of pain, you have no more pain, that's one thing. But if you're still going through it, you don't have to jump to the orthopedic just yet, especially having those like, hey, we're women between 40 and 60. We know we're going down with estrogen, all that. we need to learn how to move.
Yeah.
We need to learn how to get really strong in the right places.
Yes.
Like it's almost as simple as that. We have to get really strong in the right places.
Like bulletproof your body, like we've talked about
bulletproof
before.
it. And you could avoid years of this frozen shoulder issue just by, hey, let's get it early.
Yes.
Let's get strong and
optimize everything.
Optimize. But like this, again, this is a commitment to your health because, you know, you could go through this like 20-year period of it being very painful for you or uncomfortable in a lot of different ways.
And then you stop weight training, which we know works very much against what we need to be doing, especially for A1C levels, to combat osteoporosis and fall risk that happens as we age.
And the biggest thing I have my women call is that their weight. They're so upset about weight gain. And it's like, hey, like, please stop letting your chronic pain get in the way.
Yes.
And one of the major things is the shoulder. And so we just really want to encourage you that this doesn't have to be like this.
Yeah.
You just need the right plan to move forward and understanding where you need to go.
And I think we're highlighting it so much because I'm reflecting back on my stint in the orthopedic sports medicine world and just how I think in the US we treat problems instead of preventing them. And so we can't necessarily avoid aging. We can talk about, and set you up with providers to help get your estrogen levels optimal. But I know we can't prevent all of this from happening necessarily.
Yeah.
But you don't have to wait.
No, you don't.
And go through the chain of primary to ortho and wait for it to get worse and worse. And even the way they taught us in school was kind of archaic in terms of the different stages of frozen shoulder. And I wasn't seeing people right away.
Yeah.
So there's a stage that's called the frozen stage. And that's often when we were seeing patients and it's far too late.
Too late.
Because that's when I know you have laid out well these stages. But I think just the important thing is the way we do medicine in the US, this is not typical. So we're kind of trying to break the typical.
Yeah.
Angela and I are very much about arming you with the education so you can decide and make the decision. And you're not waiting on this archaic way we do medicine in the US.
Absolutely. It's time to be proactive.
Yes. Monday fire.
Please. On that note, later stages.
Yes. And it just stinks. I've seen you guys in these stages. It hurts. You feel vulnerable. You're not sleeping. It's a bummer.
Yeah, it's not fun. But what's like crazy is that your pain will diminish in later stages. But
you can't move your arm.
Can't move your arm.
It's joint literally capsule. Here, or you can go here maybe.
I have someone. I love her so much. She's like this. She can't.
It's gonna hurt your neck if you have headaches already.
She can't lift up. I'm not kidding. Like she's older.
Yeah.
Right. I think she's 70s. Early 70s. She's like this.
Yeah.
This is how. And then sometimes she has to go like this.
What if your job is stocking shelves at Stop and Shop, or I don't know. What if you live alone and you need?
And she lives alone, and so we have to practice and teach the muscles. Like, hey, you gotta figure this out, right? So don't do it anyway. So point.
don't wait for it
the motion starts to limit. Your shoulder's blocked.
Yeah.
So we just talked about best is acute phases because it's inflammation. It's not mechanical just yet. And then so now, if you go to the orthopedic, they might suggest a cortisone shot. Okay, like not the most ideal, but we're like, okay, this is an inflammation stage.
Yeah, we got to get that down.
But
so you can sleep.
He even says, orthopedic says, you have to complement it with movement therapy.
Yes.
You have to.
Because if you're moving abnormally, why keep...
It's going to go back.
Yes.
He literally says it will go back.
Yes.
And this can be like a bout of a year of physical therapy to combat this. Now it can be even longer. So
right. Getting it earlier, shorter time in terms of needing a rehab specialist.
It'll be shorter on your acute, but later stages.
Yeah. It's just
movement therapy will help. But patients with diabetes, we kind of mentioned before.
Yeah. Smoking history too. I remember that, slowing it down.
You're looking at a 1 to 2 year time frame.
Yeah.
Absolutely.
Feeling like you're back to yourself.
1 to 2 years. You still have to later stages, you still have to complement it with physical therapy, strength training.
And you have 2 shoulders. So you want to make sure.
It could go to the other side. Okay. And then now if you're that blocked your later stages, guess what? You might be you might have to opt in for adjustments under anesthesia. So they put you to sleep, and then they just basically manipulate
your ball and socket.
Your ball and socket
to break the adhesions. It's called, which is when we don't have time or battery life to talk, but it's
That's
just
a lot.
Stickiness, for lack of a better word, limiting the ability for that ball to glide in the capsule.
Think of like a rusty.
They crank your shoulder in extreme ranges of motion.
To be honest, that freaks me out.
It does work, but then you're in rehab to help mitigate the inflammation that creates.
Yeah, so it says you're in physical therapy for another year after that.
So we love you and we want to see you forever and ever, but we also understand you can't see us always for that many. We are lifetime. I think we do see some people through different stages, but in terms of needing, when you're in that painful, sometimes it's 3 times a week in traditional physical therapy.
Yeah.
3 days a week. I used to see people Monday, Wednesday, Friday for 4 to 6 months sometimes.
That's a lot.
Yes, I can't imagine. I have 3 kids. My husband and I both work, and then I don't know how I would get in there. And I'm 42, so this is talking to, me.
I remember when you turned 42, you're like, I'm in frozen shoulder era. And I was like, that was before we talked menopause, and I kind of laughed. I was like, is that what she thinks about?
Yes, because it's ingrained from PT school. Like, oh no, I'm in one of these like stages.
But now it's like we have a better understanding of like what control you can do. Yes. Now we could, and we'll talk about like estrogen replacement at one point too. Like I've seen it help for sure.
Yeah.
Oh yeah. And so we can talk about real quick Duke University.
Yes, she highlights in her book, Dr. Mary Haver, right? Mary Claire. I really butcher her name, and I'm a double name. Anyway, she has talked about a small study out of Duke University, 2022. So this is good, recent, for the potential for estrogen to actually prevent frozen shoulder from happening. It was a small percentage of difference, so that's why you might not have heard of this yet. But word for word, it said the women who took hormone replacement therapy had a lower percentage, 4% if I round up, of cases of frozen shoulder compared to the women who did not have the hormone replacement therapy, and that was 8%. So while that's not a massive difference, it was a smaller study.
Yeah.
We need more studies. That's the problem.
Yeah,
and who wouldn't want to just, if hormone therapy is right for you, you have to see your provider and find a provider who will help you with that. We know some. So also why it's important to work with someone who networks with these other providers to help be your care team.
Absolutely.
I think we said everything.
Anything else you want to close on with this?
I think more just my major awakening and talking to you just here live is that so much of what we see in movement patterns for females, we don't have to live with it. I think, and we learn about it in school, and we learn about it in a way like this is just going to happen to us. And I think it's really important to say, like, we're just going to be osteoporotic. We're just going to, have frozen shoulder.
Yeah, and
like, we really don't. We're not saying we're going to prevent all cases, but
life happens.
Mobility is so important. So mobility and strength training.
And it's loading your body.
Yes.
You have to load your body. And I was just listening to a longevity podcast too the other day, and it's literally his number one thing. He's a top cardiologist.
Yeah.
And
right, we didn't even talk about heart disease.
Yeah, and whatever. And he like is not on social media or anything, but he's just like, exercise. And I'm like, crazy thought, right? So
but when you're in pain, you don't want to move.
Yeah.
And I understand because I've been there.
Yeah. So. And I have too. I've had shoulder surgery, actually,
Right.
And
so you're going to have a higher,
I'm going to have a higher risk.
Tick in your box against,
Yeah. And so more of the reason why I'm going to keep strength training, and this is part of me, like this is like my life. Like I couldn't imagine a day that I'm not doing some type of exercise. And, that's what we want to get through to people. And you also don't have to exercise for hours a day.
No.
It can be quick and functional, but you, like I said, you have to find the right plan for you, especially if you're getting out of this chronic pain type of situation where it's like, find the right coach, find the right providers that understand your body, what you're going through, so that you can be set up for success, versus if you have someone that doesn't necessarily understand you or your body, they're going to put you through these generic workouts that might not actually be good for you, right? And then or just very low level rehab.
Yes.
And then you're feeling like, oh, I tried it. They said,
right.
like,
I
to try it, I
failed
broke
physical
it.
therapy. I failed.
Yeah, and it's
as a
not
trainer.
necessarily the case. You just have to find the right providers that are going to listen to you and take the time
treat
with
the
you
whole system.
and treat the whole
your
system.
whole you.
Yeah.
Not just the diagnosis that comes through on the referral.
Yeah.
See you 2 to 3 times a week for
Yep.
6 to 8 weeks. Insurance wants to see that reeval and take you through the generic pulley.
Yep.
And the PT clinic.
That's not enough.
I did it. I worked there. I was that provider.
I was actually just talking about it in my group this past weekend, how I have PTs in my group, and they're just like, in the in-network, they have a script for like one day they can work on the elbow, then the other day they can work on the knee.
That's what I used
Can't
to do
it in the same day. And it's just,
insurance
it's absolutely ridiculous. So they're not on your side. I mean, they are. I mean, but like, not really. They're just, they shouldn't be dictating what you need. And so that's why we encourage, like, explore, do your research.
Yeah.
Because you truly actually don't have to live with this.
Yeah.
Let's get it at the right time. Let's give you the right plan of care that sets you up for the rest of your life. It's not just temporary. This is for the rest of your life.
Very good close.
All right. Happy Monday.
Yes, we got this. Go lift weights.
Okay. Super duper. Episode 4 done.